This is NEJM Group coverage of the IASLC's 2022 World Conference on Lung Cancer. I'm Christine Sadlowski, and with me is Dr. Julia Rotow, a clinical oncologist at Dana-Farber Cancer Institute in Boston. We're interviewing Dr. Mariano Provencio, who is Chair of Medical Oncology at the Hospital Universitario, Puerta de Hierro, Majadahonda in Madrid, Spain. He is lead author on NADIM II, a phase 2 trial of neoadjuvant nivolumab added to chemotherapy for resectable stage 3AB non-small cell lung cancer. Dr. Provencio, welcome.
Thank you.
So first, I'd like to ask you about the history of this research, because these findings come after several previous studies, including NADIM, nivolumab in this clinical setting. Can you refresh us briefly on what is known so far?
We studied the combination with nivolumab plus chemotherapy in NADIM I. It was a clinical trial focused on stage 3A according to the 7th edition in two disease. It's a phase 2. It was a phase 2 trial, and we obtained very exciting results in overall survival, 3 times than the historical series, and the PFS around 77% at 2 years, almost double that the historical series, and also very exciting results in PCR, pathological complete response, almost 60%. And then the following action was designed a clinical trial comparing nivolumab plus chemotherapy versus chemotherapy, and this is the NADIM II.
Thank you, Dr. Provencio. So when we think about what we knew already in the field, could you take us through some of the key findings from the NADIM II study and what these might add to our current understanding of nivolumab in this setting?
Yeah. In NADIM II, the primary objective was a complete pathological response, and we obtained higher complete pathological response in experimental arm, nivo plus chemo versus chemo, or ratio 7.88. We presented in this last Congress, Lung Cancer Congress, more progression-free survival and has a ratio 0.48, and more overall survival has a ratio 0.40. And it's quite amazing results, in my opinion, comparing with chemotherapy alone.
Can I go back a little bit and say, in this particular presentation, you're showing primarily secondary outcomes, is that correct?
Yeah, we presented at ASCO the primary endpoint. It was a complete pathological response. It was positive, and then we presented in this Congress the secondary outcome, survival outcomes, yes.
And they were at 12 and 24 months, correct?
Yeah, 12 and 20 months, yes, yes.
And I was struck by the finding on overall survival that's obviously improved with adjuvant therapy.
Yeah, we use adjuvant nivolumab therapy for 6 months in patients who achieve H0 surgery. In any case, this is the first clinical trials who reported increase in overall survival in this setting of patients using immunotherapy plus chemotherapy.
Now, I was totally struck by these results, and they were quite impressive. Are there any caveats we should take away from their status as secondary versus primary outcomes on the study?
Yeah, we use in the first clinical trial in NADIM I, we use the primary endpoint was progression-free survival, and we saw the spectacular results in this aspect. And then within the pathological complete response is quite robust endpoint. I think it's quite robust, the results in the survival outcomes, because the hazard ratio is very, very important, significantly.
So what does that mean for clinical practice? I don't actually know how nivolumab is currently used. I understand it's approved for
Yeah.
other cancers, not really, not this one, but is it currently used?
Currently, we are using chemo as induction therapy, and then surgery or not. In some cases, radiotherapy in some patients, because this subgroup of patients stage 3AB N2 disease, because it's based on 7th edition. The results during the 30 years later, we have the same results using chemotherapy, radiotherapy, and so on. And then these results are quite similar than the checkmate A16, but specifically in stage 3A, 3B. In some cases, these patients are considered as a resectable disease, and we obtain very high rate of surgery, possibility of surgery in these patients. More than 90% of patients underwent radical surgery and have R0 surgery. It's quite important to the clinical practice, in my opinion. In our opinion, we should use chemo plus immunotherapy as a standard of care in this group of patients as a neoadjuvant setting.
You mentioned checkmate 816, and I know this regimen involves a slightly longer course of immunotherapy because there's the adjuvant period. Is there anything that clinicians or patients should know about adverse effects that you saw with this regimen?
I think that both trials are quite complementary results. We in checkmate 816, we don't use adjuvant therapy. I think maybe we have to have more results in adjuvant, peri-adjuvant, or adjuvant after chemo-immunotherapy. Maybe in the future we'll have to define with more detail this aspect. In any case, I think the most important part is use as induction chemo-immunotherapy.
Yeah, I thought it was great that you highlighted the surgical resection rate because it was quite a bit better with the combination chemo-immunotherapy.
Yeah, we have more than 92% of surgery in these patients. I mentioned before, 70% of patients had N2 affectation, and half of them multiple station. And it's quite high rate of radical surgery, and more than 92% of R0 surgery versus 65% in control arm. I think the surgery could be an important aspect to cure these patients.
What would you need to do next to show that?
The next steps in this case, I think we have now this is a proof of concept and introduce a new treatment in this group of patients. Very poor prognosis in this group of patients. We have almost the same survival during the last 30 years, around 30% overall survival, 5 years, and no more than 12 or 16 months PFS. I think we have to analyze with more detail. We have to design clinical trials using the response, the pathological response, and then in this case, the adjuvant treatments in these patients. For example, patients who achieve PCR in our study have 100% alive of disease 3 years, and at the same rate of about progression-free survival. All patients who achieve PCR are free of disease 3 years.
No, thank you for taking us through. I agree, these are really quite exciting results, and we're so happy to have gotten to see them at the conference this year, and we certainly look forward to seeing more of this sort of treatment strategy. So thank you for joining us today.
Thank you. Thank you.
Yes.
Yeah.
Thank you.